Welcome everyone to the March 2nd, 2021 COVID-19 clinical rounds, experiences from the Texas front lines during the recent weather emergency. My name is Richard Hunt. I'm an emergency physician serving as senior medical advisor at the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds are peer-to-peer real-time sharing of COVID-19 challenges and successes. If I'm a clinician caring for COVID patients, the clinicians I want to learn from are those clinicians with the most experience. This is a voluntary public-private collaboration, thanks to the multiple professional organizations who have collaborated on these rounds. They are not intended to be redundant or replace any organization's initiatives. They are intended to be sharing of clinical experience rather than recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on clinicians sharing their successes and challenges with other clinicians. Thanks to the National Emerging Special Pathogen Training and Education Center, NETEC, for their support with these rounds. NETEC's webinars complement these Project ECHO COVID-19 clinical rounds. Thanks to Project ECHO, Dr. Bruce Streminger and his team for the peer-to-peer learning platform we use for these rounds. Upcoming ECHO COVID-19 clinical rounds currently are all US noon Eastern time. Mondays are EMS, Tuesdays are critical care, and Thursdays are emergency department rounds. This Thursday, March 4th, the emergency department rounds will be on critical coordination of COVID, trauma, and the emergency healthcare system. Our speakers will be the current chair of the American College of Surgeons Committee on Trauma and the past chair and current past chair of the Committee on Trauma and current trauma director for the American College of Surgeons. Much like these rounds today that crosses bridges beyond COVID-19 into other challenges, that rounds will be on how we try to deal with multiple disciplines tackling COVID at the same time. Also, please note that the HHS outpatient, HHS Project ECHO outpatient therapeutics mini-series will not be held this week, and we will restart on next Wednesday. I'll now turn this over to Amanda Dizon for some logistics regarding Project ECHO. Thanks.
Thanks. Hi, my name's Amanda. I'm from Project ECHO. Just a couple of quick logistics to go over before we get started. In Zoom, you'll see a Q&A function.
Ben, I'm on a webinar or doing a Zoom thing with about 200 people, so I gotta.
Sorry about that. You'll see a Q&A function. Please use that for any questions or comments regarding the presentation. We also have a chat function on Zoom. Please use that for any questions regarding technical or logistic issues, and we'll also be using that for a crowdsourcing question. Today's session is being recorded and your attendance is consent to be recorded, so thank you. Presentations from this and all past sessions are linked on our website and will be there along with a recording. It'll take a few days to get today's, but all past ones are up there. We do offer continuing medical education credits, and we will put a link in the chat at the end of the session for a survey you can fill out. The link is also available in an announcement that went out today from Project ECHO. A quick reminder that these learning sessions are focused on patient care and health systems and supporting clinicians. And so we appreciate everybody keeping them apolitical and non-commercial. A quick note on data use. You can read our full data use policy here on the screen, but just wanted to assure everybody that while we do collect data from various places for these sessions, we don't share any individual data and it's all kept confidential. Just a note that NETEC does have webinars that are complementary to these sessions. You can go on their website to find any upcoming ones, and they also have recordings and an archive of all past webinars that they have done. Another quick note that the AAMC has a continually updated coronavirus clinical guidance repository, and we can put a link in the chat for that, and we recommend checking that out. And now back to you for the crowdsourcing question.
Yeah, thanks. This one is to serve us all. If you can answer these, this one, it's pretty simple. What are the most important topics for COVID-19 clinical rounds to address in the next 2 months? We change and pivot all the time based on what happens during the rounds, but specifically asking this question can really help inform us quite a bit. And it doesn't have to be just one topic. You can throw out 4 or 5, it doesn't matter. Hearing what you want to learn together about helps us a lot in planning for rounds. Sometimes planning is like a week ahead, sometimes it's 24 hours ahead. So just depends on what's happening in our world right now. With that, I'm going to turn it over to Dr. Jeff Dichter, who's done a marvelous job in coordinating this particular series. Jeff.
Thank you, Rick, and thank you, Amanda. Good morning, everybody. Good afternoon for those in the Eastern Time Zone. We're talking about the Texas weather emergency and its impact on hospital-based COVID care and hospital-based care in general. And just am very grateful for the input from our presenters today. Dr. Marian von Mazewski, who's Emergency Readiness Officer, Office of the Chief Operating Officer from the University of Texas MD Anderson Cancer Center. Dr. Vera Vitellani, Assistant Medical Director and Office of the Medical Director for MedStar Mobile Health Care. And an emergency medicine physician, expert in emergency medicine services. And Dr. Omar Enriquez, Associate Professor of Medicine from the Division of Pulmonary and Critical Care Medicine, University of Texas Health, San Antonio, Texas. Grateful for them. We also have input from Megan Brunson, who's the CVICU night shift supervisor, registered nurse from Medical City Dallas Hospital. She couldn't make it to the conference today, but we had a discussion. She empowered me to provide some information which she wanted us to know. So grateful for all of them. And Marian, we'll go ahead and start with you. And I know you have a brief presentation, and then we'll hear from the others and have a discussion along the way.
Good morning. Starting my timer now. So, we found here at MD Anderson that everything sort of happens around the holidays. So this was our fun Valentine's Day and Mardi Gras event that combined snow, power outages, and then a water event. So as Jeff said, I'm the Emergency Readiness Officer, which means I do all the clinical aspects of emergency preparedness for our institution. I'm also an Associate Professor in Critical Care. Our institution isn't just one hospital. We actually have inpatient and outpatient operations, which would come into play. We do about 300,000 either visits or procedures on an outpatient basis every week, as well as our research facility, which is located near Austin. We have them in Smithville and Bastrop. So on February 4th, we heard from our weather consultants, besides everyone watching the news too, about that we were going to have a pretty significant temperature anomaly in Texas starting February 13th. So we actually started at that point weatherproofing the buildings, discussions with our administration, our executive leadership regarding how this was going to affect operations. Now, many of them are from Canada and Minnesota and Michigan, and didn't quite understand how this really affects Houston, where we don't know what to do. But we really had to convince them that it cripples the city. We're not prepared. So we went through that week-long period of facilities working on buildings, us talking through all of our teams. And this is really our most recent timeline. We actually just finished recovery. But so we had a Storm Geo update on February 10th for our executive leadership so they could understand. And then we activated Incident Command on February the 11th after we'd all started working about things. So what happened is we started working on transitioning all of our ambulatory visits to virtual that could. We contacted out-of-state patients because they arrived. We started a widespread communications to our staff and our patients. Case management started working to discharge patients. We had to contact our blood vendors because we're right now at a critical shortage of O blood. I don't know if the rest of you are experiencing that too throughout the nation. And we announced the ride out 48 hours in advance because we decided we needed to go to a ride out. We consolidated our COVID unit. So it had been a little bit spread out, but what we did, instead of having so much spaces, we started closing pods and moving patients so that we could consolidate the staffing and the resources needed from that area. We knew that we had to maintain screening, and so we already worked on how we were going to do that throughout the event, because even though it was a ride out, there was a good chance people were going to be arriving, patients and staff. We worked on early discharges Sunday because the threes started arriving Sunday after dark, closed ambulatory operations early to get personnel home, and closed the non-urgent transfers late Sunday afternoon. We had canceled all of our elective Monday OR procedures and other procedures with a plan on starting probably midday Tuesday. For the ride out, we distribute cots, we have a meal plan. We use a whole lot of space because during hurricane season, we realized that with the FEMA requirements also, but social distancing, we really had to make sure that you got enough space for all the personnel to sleep. So Monday morning was super fun everywhere in Houston. Like, it was snow. We built our, 6-foot-high snowmen, and everyone was happy. It was cool. Can't get on the roads. Kids are home from school. And then what happened is our power grid failed, which I'm sure everybody else is going to talk about and you've heard on the news. Those outages also then led to burst pipes and loss of water. And this all impacted employees who were at home and at work as they were in contact with their families and heard about these things. Our public transportation had stopped. Metro is utilized by a lot of our environmental services staff, facilities, dining services. So they had already been included. We had already planned to sleep them over before we even called the ride out. The blood deliveries were completely delayed. So we had to change our transfusion parameters, especially for platelets and for type O blood. The laundry service stopped. We started getting generator alerts for our locations outside the medical center. So in some areas, the generators kicked on to maintain power to those. And we have that in the central monitoring system. Then as Monday progressed, we started getting more HVAC and fire sprinkler system alerts as the pipes were affected. Even though we'd done all the weatherproofing we could, we had airflow problems in the OR, which weren't running except for emergent cases. And then we had a fire sprinkler that went off that affected almost 2 pods of the ICU, so about 15 beds, and we had to quickly move those patients. We were able to put them in other beds because we had a vacant pod in the ICU, but at that point, then we worked on activated an empty unit that we had that had previously served sort of as overflow for ICU. So we started getting that ready. Again, we were only doing emergent cases and procedures, and there were continued temperatures lower in Smithville and Bastrop, which are, as I said, the research facilities that have about 2,000 animals each. So those ride-out teams were caring for the animals. Here are some of the scenes around the hospital. Water that had to be managed. We kept facilities teams and contractors on ride-out. There wasn't a whole lot we could do about laundry, though. So then midweek, things did slowly warm up, and our employees continued to be affected. People had completely lost water. The power grid started coming back on, but there were still some outages. And then we got the boil water notice on Wednesday. Now, Metro did resume Thursday, and laundry service resumed at a reduced rate. But again, there was that boil notice. We had to continue. We had canceled all procedures. So then because of the boil water notice, this affects sterile processing. So we had to only do emergent cases for more days. We went ahead and started taking transfers because they're cancer patients and we didn't want to delay their care. But we also, one leak led to a cooling system failure to our offsite data backup. So our data system was fine, but we have an offsite location that backs up all of our systems, some systems for UTMB in Galveston, and a couple of other hospital systems in the Houston area. So we, again, had to work on we had to initiate a water conservation plan. We needed to reopen our COVID testing for people that had either appointments scheduled or procedures scheduled the next week. So we worked to do that. We transitioned to recovery in the midst of the water conservation, but had to keep that open. We had to set up blood drives at our external facility and internal facility. So luckily our employees were all eager to donate to help the patients because of those critical shortages in the area. The local blood center also opened at that point. So we have a separate water system and are able to shut off from the city. And because of our immunocompromised patients, when there is a loss of water pressure and this happens, we shut off the city connection. We have a large well and we transition to a truck that delivers from that well to clinical areas. We had bottled water for drinking, large 5-gallon jugs with pumps for hand washing. And then we had 55-gallon drums of non-potable water to use for bucket flushing in patient areas, portable toilets for the staff. We also had to truck water to Smithville and Bastrop because if the primates quit having the water that they're trained to drink, they have to be retrained to drink water. So we had to make sure not only that they had it for survival, but that they had it in the usual quantities so that they didn't lose that training. We closed all of the non-clinical buildings. And here, when you're a research facility, the researchers get really upset about that, but we had to, and told them they could come in for limited visits, but they had to bring water, like could check on experiments, but couldn't run anything. We also had to limit some of our chemistry labs because those machines rely on water that's been sterilized and run through pumps in order to do that. We did resume some limited ambulatory activities for patients that had to have blood checks, who had to have chemo administered that had already missed it for 5 days or something like that. We opened sort of a MASH unit with scheduled appointments for that. And then again, we had to keep up that communication process. Our diagnostic imaging group was, as buildings came online outside the medical center, scheduled procedures or scheduled imaging and did about 2,000 imaging activities over a 2-day period of the weekend using those buildings and supported by bottled water and portable toilets. So the city announced that they lifted the ban Sunday in the afternoon on 2/21. So then at that point, we reconnect to the city supply. We had a huge flush brigade that came to start opening sinks, flush all the toilets. We sampled the water and then returned to normal business by most buildings by Monday morning. A couple of the research facilities weren't able to, but we had already planned that no matter what, we were gonna have to return to normal business Monday because we couldn't make our patients wait any longer. And if that meant that we were bucket flushing all of the ambulatory areas, we were ready to do it. Again, we continued recovery through the end of last week. So we increased weekend operations to reschedule missed appointments and procedures. We extended evening hours for most of our ambulatory operations. The other thing was all the employees that were affected were referred to our employee assistance program, and we also have financial support that's available through there. We've continued the facility survey and have pretty much closed that out, increased our blood donor operations. Smithville and Bastrop have just come back online. Here's some really, at the end of my 10 minutes, we had some pretty big statistics here. And one of the big things is that last one, which is we were able to tanker truck about 350,000 gallons of water to all of our locations. And that's how we handled it. We maintained incident command through last Thursday when Smithville and Bastrop came back online, and we maintained all of our COVID screening the whole time. So I don't want to take anybody else's time, and there's my info.
Thank you, Marion. Wow, that is a lot of information, but my mind spins at the amount of logistical care and timing and all the work that must have gone into it to really organize that. Let's go ahead and Veer, I know Veer, you come from the Fort Worth area and have a different perspective from the EMS. Why don't you go ahead and Marion, if you could stop sharing. Veer, I don't know if you have any slides. I didn't ask for any, and if you could just go ahead and share your experiences.
Yeah, I don't have slides. I was gonna just sort of elaborate my experiences here. So thanks again for having me. My name is Veer Vithlani. As mentioned, I'm the System Medical Director for the EMS organization here in Fort Worth. And the unique thing about our EMS system is we also run this thing called the Tarrant Medical Operations Center, which is based out of our citywide emergency operations center. So we have hands in a lot of pies when it comes to the hospitals, and I'm also an emergency physician at 2 of our big hospitals downtown. I think from the Fort Worth perspective, we followed a very similar pathway as the previous speaker just sort of mentioned. I think at the very beginning of our sort of winter weather event, we were in preparation mode. And I think from an emergency services and hospital perspective, we were in preparation mode. But before the general public could be prepared, we had a couple nights of overnight freezes where we would do the typical Texas thing, which is to freeze a small layer of precipitation overnight, and then it would thaw in the morning. Unfortunately, our public are not generally ready or aware of that, and running straight through Texas and the states above us is I-35. And I-35 in Fort Worth is one of our main thoroughfares, and we have a couple of expressways down there. And so at about 6 o'clock on the week before, really the sort of Friday before our big weather event, we had a very large pileup on I-35, and again, probably heard on national news. Essentially what happened were on our express lanes, there were sheets of ice, some semi-trailers skidded out and crashed into each other, which then led to a number of cars afterwards, upwards of 100 vehicles, ended up sliding on the ice and also being involved in this crash. We had over 100 patients. We had 6 fatalities. We had, based on the time of day, we had a number of healthcare workers that were either on their way to work or on their way back from work, not just hospital and emergency department staff, but also some of our EMS and firefighters were also involved. This presented its own set of challenges. We essentially operate an EMS system that ebbs and flows in our ability to respond to calls based on the historical call volume. So we did not have our full fleet of 60 ambulances available that early in the morning. And so we quickly rostered units from folks who were coming in and started deploying them up north. I think in total we had 40 ambulances which went and picked up patients from that area. After shutting down the freeway and beginning a sort of search and rescue pattern because of the sheer number of vehicles that were involved in this accident, we were able to quickly identify and extricate the 6 or so really critically injured patients and take them off the scene, and then continue down the search and rescue path to find everyone else who was involved in the accident. Interestingly, one of our paramedics who was actually on his way to work and so dressed in his uniform was involved in the crash. His video actually went viral of his car being slammed into and flipped up and over a semi-trailer. He actually extricated himself from the vehicle, and after a short period of being dazed and confused and seeing his colleagues there, went into typical work mode and started assessing and evaluating the patients on scene. And it wasn't into halfway through the event that someone realized he was actually in the wreck and sent him to the hospital. And so, you know, we had a great collaboration between our fire department, police department, and MedStar, the EMS organization here. And that was just the beginning. And so that was the end of the week before. And we had prepared to do an after action and get things started, but we didn't have the time. So as everyone's mentioned, really Monday, Tuesday, we started with our big winter weather, our layers of sheet of snow, which would freeze into sheets of ice overnight, and then never reach any sort of thawing temperature for the subsequent days. Thankfully, both all of our hospitals and EMS organizations were prepared ahead of time, given the events that had just occurred, and so ended up putting up most critical employees into the nearby hotels. So we pretty much bought out every nearby hotel in the hospital district, as well as near the EMS headquarters. And thankfully, we were able to maintain adequate staffing for the most part during the event. But then, as was mentioned, the power grid failure, which really is sort of the underpinning of the issues, I think that caused most of what happened in this state. If the power grid had maintained, I think things would have been a little different. So in the Fort Worth region, obviously, we had a number of power outages, both from weather damage as well as from the what were planned to be rolling outages. Unfortunately, it became apparent very early on that those who had been rolled would not get their power back in any sort of expedient fashion. Thankfully, our hospitals and those critical infrastructure places had not been hit so hard by the actual rolling blackouts, and most of them had evaded any winter weather related blackouts as well. But then the pipe freezing issues started as well. So our big issues as well related to water. We have 9 hospitals in our service area. At least 4 of them had some sort of critical issue that took down a major service line. So we had water freezes, and so a majority of our hospitals could not do dialysis. We had natural gas pipes leak and burst. And so humidity temperatures went out of control, and things like the cath labs, the IR suites, the ORs. And so a number of our service lines went down. And so then we had to essentially play the game of identifying critical patients and navigating them to facilities that could take care of them, with the understanding that getting them to a further away facility actually poses its own set of risks, not just from the EMS crews, but for those who are out on the streets going about critical business. We had a significant spike in our call volume from an EMS perspective and into the emergency department and hospitals. Obviously, essentially walk-in traffic whittled away down to 0, and all of that traffic came via EMS. And so we had a huge spike in our 911 call volume. In Fort Worth, we had almost a doubling of our 911 calls, and I know in a number of other cities in Texas, they had some double, triple, or quadruple of call volume as well. And if you understand how most EMS organizations are set up, typically speaking, there's not an immediate availability to ramp up staffing. You can't create more ambulances that are staffed out of thin air. And so we essentially adapted what we could. We had a number of people calling, continuing to call for essentially low acuity complaints. And so we set up a process where we would roll out our AMBUS, which is a quite literal a school bus that has been retrofitted into an ambulance that can safely take care of patients. We would perform screening of low acuity patients either by phone or using single responders, and then slowly essentially map a bus route for us to pick up these lower acuity patients and take them on into the hospitals. Let's see. We continued to work on supplying water for those hospitals and really the general public that weren't able to get potable water. We also suffered boil water notices, and first in our entire northern area and then our entire western catchment zone. And so we had a number of people who did not have potable water, and we ended up distributing bottled water that was donated by local facilities, and our firefighters and city responders took care of that, just staffing up water points of dispensing as well. And then of course, the other sort of big thing, when you get power failures, you get patients out in the community who are essentially beholden to electricity. So one of our biggest early indicators were patients with oxygen concentrators who no longer had power. And so they had oxygen concentrators that were not functioning. They did not have portable oxygen tanks. We did not have portable oxygen tanks that we could take to them. Our oxygen supplier was not running at the time. And so we ended up developing warming centers that patients could bring their oxygen concentrator to in order to actually continue to get oxygen. And we staffed up extra oxygen bottles there just in case as well. But obviously we run into the issue where we're telling everyone to stay off the roads because they're not safe. But then if it is safe for you, drive to this warming center. And so there were a lot of mixed messages, unfortunately. And I think everyone was essentially trying to do their best in that way. And so thankfully, we were able to set up some essential non-emergency transport services to take some of these folks using various charities and other organizations to get these folks to places where they wouldn't suffer acute illness. But we had a number of patients who, because of the lack of electricity and because of the lack of power and water, had essentially a decline in their clinical course. So patients who were normally stable or who are reliant on home health, who aren't able to get it anymore, had declines in their clinical condition, and that led to increased presentations to the emergency department, increased admissions to the hospital for patients who would otherwise have not presented. So that's pretty much the rundown of what we suffered here in Fort Worth, and very similar to the rest of the community, and happy to answer any questions.
Veer, appreciate it. And so we've heard from Houston, now in Dallas, and Omar is on. So Omar, go ahead and share with you, if you will, please, from your experiences in San Antonio.
Sure. Good morning, good afternoon to everyone. So in San Antonio, I focus mainly on the actual bedside experience that we had. Just everything that was described previously is similar to what happened here in San Antonio. Interestingly enough, the day of the actual freeze and the day after, the volumes in the hospital coming through the ED initially were not as robust as they later became. But what we did see was some disease processes that are not typically seen on a regular basis, or not very in high numbers. For example, carbon monoxide poisonings. We saw a number of those, people trying to stay warm, bringing in grills from outside, closing in any closing any ventilation in their homes to try to keep warm. And so that predisposed patients or people to get carbon monoxide poisoning. The other thing that we saw was hypothermic cardiac arrhythms or arrhythmias, cardiac arrest as well, from people who were just not able to seek shelter appropriately or were exposed to the environment. And so those were some of the diseases that we saw, and we did not have any significant power outages here at the hospital per se. The backup generators were functioning appropriately, and in terms of water, we did have issues with water, but we had enough reserves, and we're going between the city water and our reserves. And of course, there were rationings that were ongoing with the water that we did have, preferentially to patients, and the water that was given to the staff that remained on site was maintained. But the other experience that we had is obviously some of our colleagues were homebound or were stranded, not just because of the physical constraints of the freeze, but similarly their childcare or home childcare or daycares were also shut down, and so there was no place to send their kids for the day, even if the parents, one parent or both, had to work. So that was another limiting factor. So some of us that were able to stay on site kind of had to absorb that workload as well. Let's see what else. The other interesting thing that happened in our area was several dialysis centers did lose water, and they also lost water pressure, and some of the hospitals also lost water pressure. And so several dialysis patients did need to be rerouted to other hospitals, and those that normally were receiving dialysis in outpatient centers had to be routed to the hospital. On those, we had some pretty good coordination between the hospitalist service lines and the transfer centers to provide the dialysis that was needed and to facilitate their return back home as safely as possible, so as to not bog down the hospital with capacity. Those were some of the main things that I had experience with during that time. I'm happy to answer any other questions you may have.
Oh, grateful. Thank you, Omar. And I want to share just a few notes from Megan Brunson. And she's in Dallas at again, I think I'd mentioned Medical City Dallas Hospital. Some of the things that they encountered with the elevators went out and some of the elevator shafts had flooded. And as everyone has said, that traveling within the city and nearby the hospital, excuse me, had a major impact. One of the things she mentioned, which I suspect many of you may have noticed, was they had a major issue with food. Because of the difficulty with the travel, there were not a lot of deliveries. The food that they had in the hospitals were mostly directed towards patient care, as you might expect, even though the census was down. And so they had trouble finding enough food for the staff. restaurants were closed, supermarkets were closed. And as time went on, that became a more difficult issue. The staff were staying in hotels, although some of the hotels were having some of the issues. And one of the incidents you mentioned, we're bringing staff back to site at 3 o'clock in the morning when one of the hotels lost power and had flooding. They were able to send couriers back and forth from the hospital. That was dangerous with the roads during the time that the roads were really badly affected. And although there were some medication shortages, it sounded like by and large that was not severe, and that the hospitals in their community within Dallas were able to work together. So those were the things that she had shared with me. And so we'll go ahead. Again, wanted to say that I'm grateful for all of our presenters, and go ahead and open it up for questions. I'll go ahead and start. And one of the things that we've talked about on the task force for mass critical care over many different events over years is when there's a power outage, patients who are at home with appliances are badly affected. And I know, Veer, you had mentioned oxygen. I know that we've encountered other emergencies where oxygen was a major issue, both for patients at home, and it also created a stress on the health systems in the hospitals when patients went to the hospital for help. What other experiences might you share, or thoughts that might, not just the experiences, but potential solutions and things to work through? So I'll go ahead and throw that out to the whole crew. Veer, was there anything in particular that you found help for these patients other than having a warming center for them?
No, so in reality, what oftentimes happened was, patients who called essentially early enough where they had not decompensated were able to be transported directly to a warming center. But a lot of these folks ended up going to a hospital to be medically evaluated and stabilized, and then being transported from the hospital to the warming center. And so the important thing here is, so in our service area, for example, we're the only non-emergency transport provider by law. And so we had to work with some of our mutual aid partners and charity organizations that for patients who don't necessarily need an ambulance, or we sort of work to retrofit various vans and things where you don't really need, or where you can take multiple patients at the same time to get them there. Obviously in a area that not a lot of people have snow tires or snow chains or can drive safely on the snow. And so we sort of did the best we could.
Appreciate that. Marion, one of the things that impressed me about your experience in Houston, I mentioned this briefly, is the amazing amount of logistical things to be considered and the support that it must have taken to coordinate all that. Were there any particular things that you noticed that were unexpected? I know that you guys are well planned, but they were unexpected. And one of the other things that resonated from what Megan had shared with me was food. Did you guys have an issue with food during that time?
We didn't have an issue with food, but if it had gone, we were probably about 24 hours away from a food issue, in that it wasn't going to be hot meals. It would be sandwiches and stuff like that. But we were okay because we had enough advance notice that this might happen, and we knew that no matter what, it was going to affect supply delivery, so we had stocked up on that. I think the biggest confounding, we had always thought about how are we going to get blood donations during a ride out, but we didn't think we were going to be going into this with a blood shortage, and that was a huge complication. I'd say the other thing is, unfortunately, we've had practice with this. We had a water outage a year ago when a large city water main broke, so we were able to put that down, and we'd had a couple of hurricane events that allowed us to build up. We've had some good practice, and we would rather not have had that.
Thank you. Omar, were there any shortages that you noticed, or things that were unforeseen, or things that you scratch your head and said, wow, I didn't think about that you ran into during that time period?
Not really, just like what was described. We did come close. At one point, we're about 24 hours shy of having a water shortage, potable water shortage for the whole hospital. But again, the rationing and the approach that we did to that actually got us through that. Really, the shortage that I saw the most was manpower. Just people not being able to get to work, especially some service lines, and some specialties. And so a lot of some of the docs and the nurses and the techs and everyone that was there from the night prior to shift just kind of wrote it out. And of course, trying to get them some respite as soon as the opportunity presented itself. So that was the biggest shortage that I saw in terms of limiting.
Go ahead, Carol.
I'm based in Northeast Ohio, and we kind of had a not as bad of a situation, but during blackout 2003, we had no power for days. And one of the good things that came out of that is a lot of systems developed volunteer registries for patients with functional needs, people with oxygen needs, et cetera, other special medical needs. And I was just wondering if any of your systems tapped into that, if it existed, and if not, is that something you would create in the future, potentially based at your emergency operations centers, those type of registries?
You mean volunteers for medical or non-medical?
No, for people with functional needs to volunteer their medical information to create a registry. You know, it can't be mandatory, obviously, because of patient
Yeah.
confidentiality. But we have several systems now that after that event, you know, we had that because you mentioned people coming for medical care. If they just could call the EOC or the EOC knew where they were, they could go and get these people, whether it was opening up a gym with backup power or whatever, just to plug into oxygen before they had a need to require medical care.
Yeah, we have a list sort of like that of patients on home ventilators, home oxygen, that sort of thing. But again, I think the access to and from these patients was the biggest issue for us.
And I don't know that all of you were living here, living in Texas in 2011, but we keep hearing in the news, at least I keep hearing in the news, that the last time there'd been an event of this was about 10 years ago. And when you look to the past, I mean, were there learnings from that helped you in this situation? Probably unfair, even if you were involved, you may not have a memory that goes back 10 years.
Yeah, I wasn't here back then.
And what are the things, when you look to the future, when you do planning based on this event, what are the learnings? Are there learnings? I mean, you're not going to see a weather event like this very often in Texas, obviously. But are there any other things that you took from it that you'll carry forward, that in particular that stood out?
Well, I just hope we don't have to combine this with all how it disrupted our COVID screening and testing, like that disruption of COVID testing then delayed what we were able to do afterwards, because clearing patients for procedures and stuff was affected.
Were there any other shortages? I mean, one of the things I think of our census, our COVID census is a little bit less in Minnesota right now. But when you think about PPE, I mean, they're labor-intensive patients depending upon how many you have at this point in time. But there's PPE to be considered, in particular, which resonates with me. Testing, as you've mentioned. Were there any shortages that anybody noted in terms of management of that patient population, given that we're in the middle of a pandemic?
No, I think most of our facilities, yeah, we either have good stockpiles or you know, a lot of our services switch to reusable respirators, wipeable ones, et cetera. So.
How about you, Omar? Were there any things that created difficulty in managing the care of your COVID populations?
Yeah, the only difficulty that we had was that the week prior to the freeze, we had just defunct one of our backup teams for COVID. So we were in the process of kind of reorganizing and restructuring and consolidating our COVID patients. So that was one factor. The second factor, that we were in the process of consolidating and defuncting another stage of our COVID surge backup or model. And so that kind of came to a halt, and we were kind of stuck in limbo with trying to consolidate in terms of geographical location for efficiency and things like that. But we had all the resources that we needed to take care of the patients. So there was no materials that were needed or any equipment or anything like that. It was just kind of that clanky transition that happened, and it was slower and more paused because of the freeze and the manpower absence that was not at the hospital.
Have all of you gotten back? Go ahead, Ryan.
No, please finish, sir.
I know. Have you all gotten back to normal? What things are you still working on right now?
We still have water main breaks at various places in the city, and have been working on those for quite a while. Thankfully, all the boil notices are over, but we still have some people without water.
Yeah, it's an ongoing issue. Our staff are having to miss work because of damage to their homes to take care of that.
Yeah, I was going to mention, so a lot of the docs that kind of put all that aside, or their residences, they had to go back the week later or after everything thawed out, and now have to tend to busted lines and whatnot. So in terms of the actual power, water outages and boiling notices, all that is pretty much resolved. We have pretty much gone back to our pre-freeze state per se in the hospital, but there's still some residual effects from that.
Ryan, did you have a question?
Not a question, just an observation. So much that we obviously in emergency preparedness, and I'm having flashbacks right now to my time as my hospital's emergency management chair about all hazards approaches. And I'm curious, for those of you who just lived through this, I work in San Diego, a city that can barely cope with rain, much less snow, right? If we went through what you went through, it would be, the apocalypse. But but the possibility of something analogous here, for example, an earthquake happening during COVID, wildfires happening during COVID, those are all things that clearly could happen. And so I'm curious if you've thought, if any of you have any thoughts, and this is sort of an out of nowhere question, about kind of generalizability of overlapping disasters. Is there any kind of grand unified theme that you would think of about what do you do when you have more than one disaster at the same time, in terms of an approach that folks in sort of geographically distinct areas could take forward? And if that's not a fair question, I retract it and I apologize in advance.
So Ryan, I'm laughing because actually today I'm giving a presentation about why an all hazards approach doesn't work in patient care, because these random little things like a water outage that you really don't all hazards for can disrupt patient care so horribly. I mean, we found that out last February. And so we pulled that through, but we're actually going to talk about that in our thing. So you have to look at all the little things, and all hazards doesn't cover it. But some of those principles are the same. Like a write out's a write out, whatever it's for, it doesn't matter. But it certainly, these things certainly do make you nimble when you're looking at having these, because to me, there were 3 separate disasters. We went from ice and you couldn't get to work to electricity. I mean, all our generators worked in-house, but then that whole virtual care that we've done during COVID fell through. And then the water part was, something we haven't had it to that extent in Houston forever. And when they talked about that our power grid was supposedly 2 or 4 hours away from completely failing throughout the state, that gives you a lot of thought about, generators only last so long.
Yeah.
I don't think we're all really prepared.
Thank you, ma'am. I think Jeff's moderating, but Dr. Cunningham?
No,
Go ahead.
I just had a comment. I think that out of all the things you mentioned, the one thing you cannot live without is water. And for years, I've always dared hospital administrators to have a disaster drill where we've lost our water supply. Until this day, I've not seen anybody actually take on that challenge. But this certainly is an impetus to really think about that. You cannot live without water.
Yeah, we're very fortunate at my hospital. We actually have a very large auxiliary water tank, 1 million gallons plus underneath a little park on our campus here. But if it froze, I don't know what we would do if California ever got actually cold and we had to deal with, for example.
Well, I am even thinking, I'm not just in the hospital, but if a community lost water, they all are not going to pile to the hospital to get a drink of water. It's a real challenge, and it's something we should think about. What kind of avenues are we going to have to replace that one vital resource?
Power was something also I know that affected everybody during the Texas weather emergency. And Dr. Mukherjee, who's on the call from Bellevue, unfortunately had to drop off early, but much experience on power outages from the Hurricane Sandy in 2012. And I had heard a nice seminar and several nice talks about the consequences of not being able to have power. They were able to maintain, obviously, huge consequences because they lost their generator, and they had an accessory generator on the 13th floor, which they were ultimately able to maintain. But I know when I heard the power grid, I know that the hospitals had power supplies in Texas, but there's a limit to how much oil you have or how long a hospital-based generator can maintain power for. Was there ever any concern about that? I mean, Marion, obviously you had voiced it. Omar or Veer, had you guys run into issues of power during that time?
No issues in San Antonio. I know there were some, and there were some hospitals that did have some issues, but they were very short-lived and resolved. Most of the surrounding hospitals in the area mainly had issues with water pressure and water pressure mainly. They did not lose water per se. They just lost water pressure to the point where they were not able to provide dialysis or adequate care. So some of those patients, not just in the ED, but hospitalized, also had to be transferred out.
Yeah, no, thankfully none of our hospitals really had big power issues that I'm aware of.
Thank you. It sounds like everybody had plenty of the resources they need to provide COVID care. There was no issues with PPE, I heard. Supplies were good. One of the other things, it sounds like most of what you've described and from other colleagues I've met, when everybody powered down their hospitals and decreased their elective things, it sounds like the hospital census became less and was more manageable that way. Omar, had you guys found that? Had you guys gotten to the point where you had to decrease your hospital? You canceled elective surgeries and whatnot, or how close did you come to being able to maintain normal functions?
So we were able to maintain normal function through the freeze. And that was kind of our, like I mentioned, we were getting ready to defunct some of our backup systems or our backup models and teams for COVID support. And so those were still somewhat active. So that reserve of capacity was still available. And so the freeze put that on halt. And then when you had a decrease in number of patients that were coming in by private vehicle, that kind of stalled. But as soon as everything warmed up, I mean, the floodgates opened up, and all those patients that were homebound for several days and waiting for the first opportunity to get out and get to the hospital, they came in, and we see ourselves now being quite busy and quite full.
Asha had sent me a note, and the question I have, and there's a note in the chat here as well, were cell phones affected? Did anybody encounter the cell phones being affected? And was there any issue with telemedicine services providing backup for patient care needs? I know we've gone to virtual in the pandemic, trying to reach out to our patients at home, and it sounded like there was some disruption there. So cell phones and telemedicine effects. Could all of you comment on that just a little bit more?
Yeah, there was intermittent cell phone instability with connectivity, but for the most part they were functioning. The only issue with cell phone was for charging. But in terms of telemedicine, I couldn't speak to that. We don't have that here, and at least not in any of the inpatient services lines.
Marion, did you notice any effect on the cell phone or any of the telemedicine services?
Actually, exactly what he said. We had some unstable networks so that connectivity would come in and out, but the biggest problem was charging. People were going out to their cars to charge, but patients weren't able to do that. So really most of our virtual things fell apart.
Yeah, we did okay for the most part. I saw a comment about the EMS side. Most of our EMS organizations are on FirstNet, which is the governmental sort of emergency cell phone network. And so for the most part, we did all right.
Yeah, that's weird because our FirstNet was affected. It was kind of strange.
Yeah, I mean, I guess it depends on the towers, right? Like, as far as I'm aware, right? Because it all broadcasts off the same towers, is my understanding. So our towers didn't go down, it seems.
So we're almost at the top of the hour. Are there any other, if you guys had to give a message to the political leadership of state of priorities to prevent this from going forward, what would be the top 2 or 3 things you would ask them to think about?
Regulate the grid.
Yeah,
The power grid was
winterize the
really-
electrical grid. Yeah.
I appreciate that. I have a feeling you're going to have plenty of company supporting you on that one. All right. Well, we're right at the top of the hour. Grateful to all of our participants again. Veer, Omar, and Marion, thank you so much for all being here. Thank you for Megan as well for the input that she was able to provide. And Amanda, we'll go ahead and turn it back over to you. Also grateful to our panelists. Thank you to Ryan, Asha, Ahmed Apal, and Vikram Mukherjee. And Carol and all of our routines, and Rick probably, and I know there were a few I missed, so I'm going to apologize in advance. Harry.
And a thank you to everybody from Project Echo, and the link for CME is in the chat, and we appreciate everybody filling it out. That's it from us.
Thank you all.